If I am treating a large cyst, a cavity in the lower jaw, of course I would like it to be regenerated. That means even a young patient should not be able to notice the difference between their own bone and the defect in a couple of years. This is where regenerative materials, such as beta-tricalcium phosphate, provide a good solution nowadays. For example, CERASORB is a graft material which can be applied to achieve complete regeneration due to the complete biological remodeling of the material, thus enabling complete integration and regeneration. However, if I have to deal with significant atrophy in older patients in areas where I want to regenerate and reconstruct the jawbone three-dimensionally, I also need a certain level of volume stability. This makes it desirable, for example, to mix beta-tricalcium phosphate or even introduce hydroxyapatite, for example, osborne, because it provides more volume stability. The affected area is remodeled and resorbed for the longer term. This results in increased volume constancy and greater strength, even when dealing with osteoporotic bones, for example. The same exact applies with regard to the paste. I sometimes have to treat minor periimplantitis defects, which can prove difficult to tackle. This is why it is great to have paste-like structures that can be used to fill these in. One has to consider the possibility of utilizing a membrane cover, since pastes, naturally enough, also tend to flow and spread. From our experience, one should also try to prevent ectopic formations from occurring and ensure that the material does not reach unwanted areas. However, as a result, I believe that all indication classes can be covered, and the expertise of the practitioner is of course required when it comes to deciding which material is most appropriate for the given defect. I was one of the very first users of the product. I worked at the Göttingen University Clinic for many years, and we were already using it in 1997, the original CERASORB back then, due to the great benefits it offers to patients. I do not need external bone harvesting, nor any additional defect. The great thing about it is, bone regeneration occurs without the patient suffering any additional discomfort. This means that I can treat large defects or perform a sinus lift augmentation, mix the material with the patient's own blood, which accumulates in the wound anyway, have no need for additional harvesting, and still expect a good regeneration result. In my opinion, that is the crucial difference to the alternatives on offer. For example, bovine materials, which may indeed be incorporated, or at least integrated into the tissue, but no actual physiological bone regeneration occurs, and that is the big difference, I believe. Another important point is that we are dealing with a synthetic material, which poses no risks and causes no allergic reactions or prion contamination. This ensures the highest standards of safety for patients, and I believe that these are the crucial arguments that support the use of this material.